Now, let us go to the clinical feature. An important question that is asked to us in the examination is that what is the most common presentation of breast cancer? So the answer is that more than 75% of the patients will present with a lump. So most common presentation is a breast lump. Again, another exam question. Which is the most common location or region for having a breast lump? The answer is upper outer quadrant. And why is it so? Because most of the breast tissue is present over there. It is densely populated with the various breast tissues. So this is the reason why upper outer quadrant is the commonest area to have a breast lump. Suppose in the exam they ask which is the second most common area to have breast malignancy or lump, then it will be retroareolar. It's also called as region. So behind the nipple areola region is the retroareolar. Okay, so that is the second most common place to have a breast lump. If they ask you which is the region where you will have least chances of breast malignancy, then exactly lower inner quadrant. Lower inner quadrant is the one which has the least chances of having malignancy. All right. Now, apart from that, how the person can present? Person can present with a breast lump. Person can present with a nipple discharge. There can be ulceration. There can be retraction of the nipple. All right. So these are the various ways in which a person can present. The person can also present with features of secondary, such as jaundice, bone pain, fracture, etc., or lung metastasis. All right. Now let us go to some physical findings. Okay. So physical findings. One is fixity. What do we mean by fixity? There is a breast lump. If you try to pinch the skin above it, you will not be able to do that. That is known as fixity, and that is because of the involvement of the skin. So cancer cells infiltrate the skin, and hence the cancer becomes fixed to the skin. This is known as fixity. There is another thing called as teethering. What do we mean by teethering? There is a breast lump. You try to pull the skin above it, it will be lifted easily. Now you try to move the lump. The lump will move, but whenever you come to a particular position, there will be dimpling of the skin or retraction of the skin. This is known as teethering. So when you push the lump to a particular extent, you will see that the skin is getting pulled with the lump and a dimple is being formed on the surface. Why does this happen? This happens because not the skin, but the Ashley Cooper ligaments are involved by this malignancy, and that is why this is happening. Now, what else can we see? Sometimes the cutaneous lymphatics are involved. Because of this, there is edema, cutaneous lymphedema. And when there is edema, what happens is that there is a swelling, and the skin is fixed to areas where the hair follicles are coming out. So it is very similar to a person making a mattress. If you've seen a person making a mattress, he fills that cloth with cotton, so the cloth actually bulges out, and wherever he takes the stitch, the cloth is adherent over there, whereas the rest of the places it is bulging. All right, this is exactly what is happening because of the cutaneous lymphedema. If you see from top, it looks as if it is the peel of an orange, so it is called as an orange peel appearance or peau d'orange appearance, and this is due to the lymphatics. This is dermal or cutaneous lymphatics. Again, the cells might grow in the cutaneous lymphatics. They might block the lymphatics from both the sides and form small nodules because of their growth. Multiple such nodules may be seen on the skin. So whenever a person sees that, it looks as if the person is wearing the armor coat which they used to wear in the wars before. And this is known as the armor coat appearance. It is also called as cancer en cuirasse or armor coat appearance. So that is another physical finding that one gets, and that is because of the involvement of the lymphatics and growth taking place. Alright. So these are the various physical findings that one is likely to find. Of course, there can be others like retraction of the nipple. There will be fixity of the. There might be fixity of the lump to the chest wall or the skin, etc. Alright. But these are important physical findings which are likely to be asked in the examination. Now, let us go to the pathology. Let us briefly study pathology. Before we start with anything, let us go to the in situ carcinoma. So we will start with ductal carcinoma in situ. Two varieties, ductal carcinoma in situ and lobular carcinoma in situ. So how does the ductal carcinoma in situ present? The most common presentation is that when you do a mammography for screening or for whatever reason, there will be calcifications, and these microcalcifications, if you do a biopsy, you will find that there is the ductal carcinoma in situ. In situ means that the basement membrane has not been invaded. Alright. What is the investigation of choice? The investigation of choice is mammography. Now, if a person has ductal carcinoma in situ, how do you treat it? Treatment is by local excision or wide excision. Once you excise, you see various parameters and you do a scoring called as Von News Index, okay? Von News Prognostic Index. Why do we need to do this? We need to do this because This von Neuss prognostic index will guide us whether we should give radiotherapy to this patient or not. Whether we should give radiotherapy or not. This is von Neuss prognostic index. Important, please remember, they can ask you in the examination. The other in situ carcinoma is the lobular carcinoma in situ. Lobular carcinoma in situ is likely to be multicentric. We saw what multicentricity is. And it is likely to be bilateral. So this is an important thing that you must remember in our examination, multicentric and bilateral. Itself, it does not cause malignancy, but it increases the risk for malignancy. All right? So it increases the risk for malignancy. And whenever there is malignancy in this kind of a patient, then that malignancy is more likely to be invasive ductal malignancy rather than invasive lobular malignancy. We need to know the microscopic characteristic of LCIS. Okay? Microscopic characteristics of LCIS. So, mucoid cytoplasmic lobules. Mucoid cytoplasmic lobules. That is one characteristic. All right? Apart from this, what is the other characteristic? The cells are arranged in a straight line. This is known as the Indian file pattern. Again, important for your examination. Indian file pattern. Cells are arranged in a straight line. And the calcification, the calcium is not concentrated at one end, but they are distributed to the neighboring cells also. And this is known as the neighborhood calcification. Neighborhood calcification. All right. These are some of the characteristics of LCIS. What is the investigation of choice? It is MRI, magnetic resonance imaging. Now, what is the treatment that we need to give for lobular carcinoma in situ? So basically, it itself is not a pre-malignant lesion. So the malignancy need not develop in that area itself to detect LCIS. Both the breasts are at risk. So we have 2 or 3 options. One of the options is just to observe. If the patient is ready to come regularly for observation and does not want any other intervention, then we just need to observe the lady time and again to see whether there is any development of a tumor which we need to operate upon. The other thing that we can do is a chemoprophylaxis with hormonal treatment. And the third thing that we can do is that if the lady is willing and if she is very skeptical, then we can do a bilateral mastectomy. So these are the 3 approaches that have been described. One is observation, the other is chemoprevention, and the third is prophylactic mastectomy. Now, let us go to the invasive cancers. All right. So, as far as invasive cancer is concerned, if you are asked, which is the most common pathological variety of breast cancer, it is infiltrating ductal carcinoma. Infiltrating ductal carcinoma. Pathologically, the most common cancer is infiltrating ductal carcinoma, and the pathologist uses a modified Bloom-Richardson scoring system to score it. All right. Then, if you are asked that which is that tumor or which is that cancer which is likely to be bilateral, the answer is infiltrating lobular carcinoma. Which cancer is likely to be bilateral? It is infiltrating lobular carcinoma. This is likely to be bilateral. Then, let us see medullary carcinoma. Let us see medullary carcinoma. What is the characteristic of this? This is likely to be associated with BRCA1 gene mutations. This is likely to be associated with BRCA1 mutation, and it is likely to be a hemorrhagic tumor. It is likely to be a hemorrhagic tumor. Then we have a mucinous carcinoma. What is the characteristic? The tumor is extremely bulky. The tumor in this is extremely bulky. Alright? And you are usually likely to see it in the elderly patient. Elderly patient. Okay? Next is the papillary carcinoma, and as the name suggests that there will be papillae. Next is the papillary carcinoma, and as the name suggests there will be multilayered epithelial papillae that will be seen on microscopy in this particular malignancy. Then there is something called as inflammatory carcinoma. So what happens in the inflammatory carcinoma is that the cutaneous lymphatics are blocked, and as a result of which there is extreme inflammation that one sees in this particular type of cancer. So what is the importance of inflammatory carcinoma? If you are asked the type of breast cancer with the worst prognosis, it is the inflammatory variety. Type of breast cancer with the worst prognosis is inflammatory carcinoma of the breast. And what happens? There is involvement of the subcutaneous lymphatics. If you are asked which is the one with the best prognosis, you can say it is tubular carcinoma. Carcinoma, almost 100% survival is seen in tubular carcinoma. Okay, so now we will go to Tmm classification. Okay, so we all know what is Tmm. T stands for tumor, N stands for nodes, and M stands for metastasis. Okay, so let us see the AJCC Tmm classification. This is the 8th AJCC Tmm classification, which is the latest, which has come out in 2017 after modification. All right, so we'll start with T. What is T0? T0 is when there is no evidence of primary tumor. T0 is no evidence of primary tumor. So there is a possibility that a lady comes to your OPD with a lump in the axilla. You biopsy it, and the pathologist tells you that this is a malignancy, this is a secondary from breast cancer. Okay, so primarily you are not able to detect any malignancy, but the metastasis is there. So that is T0. Then that is T0. Then Tx. What do we mean by Tx? Tx means that you do not know anything about the primary. There was something primary, but you do not know anything about the primary. Now, the thing about this is that maybe the person has been operated somewhere else, has taken some treatment somewhere else, and then has changed the cities, come to you, and unfortunately that person has forgotten to bring records, or those records have been destroyed due to some natural calamity. And hence you do not know what was the status of the primary tumor, so we do not know the status of the primary tumor. Then we come to T1. Then we come to T1. T1 is a tumor which is less than or equal to 2 centimeters in the greatest dimensions. Less than or equal to 2 centimeters in the greatest dimensions. Alright? Before we go to this, there is one thing I forgot to tell you, and that is TIS. TIS is carcinoma in situ, And the latest AJCC gives two varieties. One is the ductal carcinoma in situ, and the other variety is the Paget's, the in situ variety of Paget's disease. Alright, these are the two things that are given. Lcis, that is lobular carcinoma in situ, is not included because the AJCC says that it is just a high risk factor and not a pre-malignant condition as such, and so they have not included this in that. Okay, now what is T2? T2 is a tumor between 2 to 5 centimeters in the greatest dimensions. Alright, T3 is a tumor which is more than 5 centimeters in greatest dimensions. Now all these tumors are just present free from the skin, free from the other tissues. Okay, so they are within the breast, confined to the breast. T1 is up to 2 centimeters, T2 is 2 to 5 centimeters, and T3 is more than 5 centimeters. Now what happens when this tumor starts invading other tissues like the skin or the chest wall? So then it goes in T4. Now in T4 we have T4A where there is an invasion of the chest wall. We have T4B when there is invasion of the skin. We have T4C where it is a combination of both of these. So chest wall as well as the skin has been invaded. And then we have T4D where there is inflammatory carcinoma. Inflammatory carcinoma. But this is what we need to remember and understand. What is the latest modification in the latest AJCC? What they say? This is 20 millimeters, right? That is 2 centimeters. They further divide it into a microscopic variety, A variety and B variety. So the microscopic variety is less than or equal to 1 millimeter in size. T1A is up to 10 millimeters in size. Sorry. T1A is up to 5 millimeters in size. T1B is from 5 to 10 millimeters in size. And T1C is 10 to 20 millimeters in size. So T1A is 1 to 5 millimeters. T1B is 5 to 10 millimeters. And T1C is 10 to 20 millimeters. And T microscopic is less than or equal to 1 millimeter. It is not necessary for you to remember, but if you are interested in surgery and if you have revised everything else, then you can also remember these values, T1A, T1B, T1C, and T1 microscopic. Alright, so this is what the latest AJCC tells us. So this is about the T classification. Now let us go to the N classification, that is the lymph nodal classification. Just as we have N0 and a T0 and Tx, we have N0 and Nx. So what is N0? Clinically, there is no palpable lymph node, or clinically we cannot say that any lymph node is involved. Okay, so you palpate the axilla, axilla is free, nothing else is palpable. Alright, that is N0 lymph node. What is Nx? Nx is again person operated or treated outside. Maybe surgery was done, but you do not know exactly what is the status of the lymph node. So probably the details are not available. Then we have N1, N2, and N3. So let us see how they are. So let us make this small table. So if a person has an ipsilateral axillary lymph nodes which are palpable and freely mobile, only one group, that is axillary lymph nodes, that also of the ipsilateral side, and that also freely mobile, not fixed, then you will call it as an N1. Alright? Now there are two things, axillary and mobile. So suppose a person has an ipsilateral axillary lymph nodes, palpable, but they are not mobile, instead they are fixed. Single group, that is axillary lymph nodes, again of the ipsilateral side. The only difference from N1 is that instead of being mobile, if they are fixed, then you will call it as N2A. Instead of axillary lymph nodes, clinically if you are able to palpate the internal mammary group, then it is N2B. So N2B is internal mammary group. Again a single group, no axillary involvement, only internal mammary involvement. Then look at N3, N3A, N3B, and N3C. So ipsilateral infraclavicular. We know that apical group we call it as infraclavicular. So infraclavicular ipsilateral side positive, again single group of lymph nodes, then you call it as N3A. Instead, ipsilateral axillary plus internal mammary. That means you have more than one group of lymph nodes positive, then you call it as N2B. And if ipsilateral supraclavicular nodes are positive, again single group, then you call it as N3C. Now the importance of supraclavicular is that if you see some of the earlier classification, supraclavicular was put in the metastasis. Now the recent classification puts it as 3C. Okay, so this is how the lymph nodes are classified. As far as metastasis is concerned, if there is presence of distant metastasis, it is M1. If there is no presence of distant metastasis, it is M0. Okay. If there is presence of distant metastasis, it is M1, and if there is no presence of distant metastasis, it is M0. Now, after having understood the T and M version, let us see how we actually stage it. Okay, so if it is T1N0, we call it as stage 1. If it is T2N0, or if it is T0N1 or T1N1, then we call it as 2A. Alright? Instead, if it is T3N0 or T2N1, then we call it as 2B. This is 3A, that is T3N1, or T0, T1, T2, T3 with N2. This is 3A. Or the T4 varieties up to N2 are T3B, and all the N3s are T3C. So this is how we classify. I think, according to me, this is the most important TNM that might be asked to you. Apart from this, in head and neck cancer, they might ask you TNM. Otherwise, they are not very fond of asking you this kind of stagings anywhere else. Okay, so this is about the TNM classification. Now, there is another very recent concept that is a molecular classification of breast cancer. So we will just see that. Okay, so it is based upon the presence of ER, that is estrogen receptor positive, progesterone receptor positive, and HER2 positive. All right. So there might be a condition where ER, PR, that is estrogen receptor, progesterone receptors are positive, and this HER is negative. Now, this type of cancers are called as luminal A cancers. Luminal A. There is also a possibility that all the three might be positive, triple positive cancers. Luminal B type of cancers. All right. Then there might be a possibility that instead of triple positive, it might be a triple negative cancer, which means this is also negative, this is also negative, this is also negative. This is called as a basal cell type cancer. Also, these are called as triple negative cancers. So many times you will read in your textbooks triple negative cancer. So what are these? These are the types of cancers where estrogen receptors are not positive, progesterone receptors are not positive, and HER2 receptors are also not positive. This is a basal cell type cancer. Then there is an HER2 type of cancer, which is exactly opposite of luminal A. That is, ER, PR both are negative, and HER2 is positive. So this is the molecular classification that you must know.